Hypersensitivity 4. We talked about type 1, type 2, type 3. Let's talk about 4. And just wanted you to make sure that you know the differences between these 4. That's why I'm taking up the basic scientific stuff in these lectures, and the clinical part will be dealt with in the workshop. Because as a pharmacist, you will come across hypersensitivity reaction, allergic reaction, very common side effect of quite a few drugs available. Now again, remember that as far as immune response is concerned, team is the same, cells are the same, receptors may be different, cytokines may be different, since we are using different types of management and drugs in different type of hypersensitivity reactions. So type 4. The most important thing about this reaction is that it is cell-mediated. Cell-mediated. That's the prime part of this immune response. It doesn't mean that the previous did not involve cells, but again, the major culprit, the major player is cell. And what normally happens is, again, you keep in mind that we spent 10 lectures on teaching you what is normal immune response, how things are normally dealt with our immune system, and then of course things can go wrong and out of control or disproportional, just like orchestra, because even one person is not playing whatever he's supposed to play, it's going to be an odd tone, odd sound. So that exactly happens in our immune system. All the players have to be a part of the synchronous response. And sometimes our immune system fails to do that, and we end up giving it a response that is more than desired. That's what you end up with hypersensitivity or allergy, or a response that is good enough to kill bacteria or viruses or fungi or take care of the dead material and help you proliferate your normal cell lines, and all of a sudden it's out of control, disproportionate, and the same players cause you tissue damage. So you will have a tissue damage, sometimes to such an extent that you may see a reaction on your skin to asthma, to many different skin diseases, autoimmune diseases, and it's difficult and to basically control. So in this case, again, since it's a cell-mediated, so antigen-specific T lymphocytes. So these are antigen-specific T lymphocytes that normally should activate, should proliferate, and should mobilize, but this time they do, but disproportionately. So they would lead to, so to speak, a storm of cytokines. And again, if there are too many cytokines running in your system, it will be very deleterious and dangerous for you, to such an extent that even can cause shock. So there's an inappropriate release of cytokines, very high levels of cytokines. Remember cytokines, if you remember, chapter 11 we talked about that they are like hormones. They are released in very small quantities, and they have a good way of dealing with the situation in very low doses. But all of a sudden they are in high quantities in circulation and will cause the damage. The other name for type 4 hypersensitivity reaction is delayed type hypersensitivity, DTH. This is in comparison to antibody response, because antibody response sometimes, especially for type 1, if you are already sensitized, it will be immediate. So the moment you inhale, the moment you touch, the moment you eat, drink, whatever, it's going to lead to an enormous spontaneous response, anaphylaxis. But in this case, the response is delayed. And I gave you an example as well for the tuberculin test that you do before you come to the college or before you take any appointment or job. It's mandatory. for employers to offer Montos tests on the day of your birth. That's pretty much it. So they just inject you with an antigen that is a mycobacterium, and then see a purified derivative of mycobacterium, and then see how your system reacts. And then they will follow you up for 72 hours. Again, as I told you, they will always ask you that, were you BCG vaccinated? So if you're BCG vaccinated, that happens almost all the countries of the world other than US. So you should not offer yourself to be given PPD tests. You would rather go for a chest X-ray. So delayed type hypersensitivity. Now also, I think you by now get a pretty much good idea that when we say immune reactions, we basically will talk of antigen. And one of the things I want you to take from today's lecture is that depends upon the dose of antigen. So they give you the PPD, purified protein derivative. That's what it stands for, purified protein derivative, PPD. A very calibrated dose of PPD. And then they are measuring the circumference of the actual area. They'll just mark it up and see how do you react. So they will be anywhere from erythema, redness, to a fulminant tissue damage that some people may have. But also remember, the question is, why does body have this type of reaction? Because these type of reactions we need to take care of viruses, bacteria, fungi, and even cancers. So that will be considered a beneficial. So always keep in mind the immune system is there for your benefit. It's only when things go out of control, when the antigen, the one that elicits the immune response, that is too much. So there's always a very precise balance between a benefit and harm. So which way is going to tilt? So harmful effect of a delayed type hypersensitivity shows itself extreme form autoimmunity, and milder form some of the allergies, especially dermatitis, skin allergy, jewelry, clothes, cosmetics, anything which is there is chronically irritating either your mucosa or the skin. So you will have inflammation of the skin. I would not discuss dermatology with you, but just to remind you, when I did talk about skin in physiology, I said that normally skin sloughs off the superficial layer. So there is a time period when this sloughing off of the superficial layer takes place. If you increase the time, then there is a skin disease. I also give an example that from the skull, that if your outermost layer of the skull starts shedding off the superficial layer in a very fast way, you may get dandruff. So that's like a dandruff falling on your eyes, falling on yourself, and then you apply all those different shampoos and so on and so forth, selenium sulfite, and many drugs are available. So dermatitis remains as a major problem. And I also remember saying to you, skin diseases are difficult to treat, and they are, well, they are noticeable. People do care about their skin, but sometimes it's beyond our control, especially when it comes to allergies, delayed type hypersensitivities. Now, based upon your immune knowledge of immunity, you know anything that touches skin or mucous membrane, especially skin. So we have the most professional antigen-presenting cells, Langerhans cells. They are type of dendritic cells which present an antigen, and they have an ability to present an antigen in a unique way because it's a protective mechanism. And skin also remains one of the largest organ in the body. So our Langerhans cells at any given time are sensing the external environment that you may have on your exterior. Okay? Now, what typically happens is that if you were to test, for example, let me give you a PPD example because I'm pretty sure all of you are familiar with that. Is that correct? Those of you who didn't have a BCG vaccination, so they would have seen that. So what normally happens is that they pick up the front of your arm so that you can visualize and see it, and just intradermally, they give you that antigen. So the moment they give you an antigen, which is an antigen obtained from Mycobacterium, that is notorious for causing delay type reaction, is a purified protein derivative. So you know proteins, how proteins are dealt. So immediately antigen presenting cells will come, we'll take it in, break it apart, take a portion of it, present it to the T cells. Now, one thing I may or may not have mentioned, or you did not pay attention when I did mention, was that any antigen that enters your body, there are T cells called memory T cells. They are memory T cells, and they have the data for each and everything that you were exposed to in the past. So they keep a data on that. So they just want to make sure is it your first visit or any subsequent visit. So if you've been exposed to Mycobacterium, like the case of BCG, so memory cells will pick it up. And they know how to deal with you because they will call in everything that they have, and then you will have a very fast kind of a response in terms of how to deal with you, because Mycobacterium is nothing, not a good thing for you to have on your skin or any part of the body. So antigen presentation, presenting a protein derivative to T cells. And after that, you pretty much are familiar with what happens. The immune response is the same. Once an antigen is presented, then T cell will take an effect. So they will call in. So we have Th0 called naive T cell. They will proliferate into Th1 and Th17 type cells. And then again, as we know, Th1 type have a very specific response. They will call in. What is the most important cytokine that you think Th1 is going to call in or synthesize or release? Say it again. Louder. Yeah, interferon gamma, that's the most important thing. Interferon gamma is the most important thing that is there. And then again, tons of other. But is it a pro-inflammatory cytokine cascade or an anti-inflammatory? Th2 is anti. Th1 is a pro-inflammatory cytokine. Th3 can also act as that, but the major pro-inflammatory cytokine release is Th1. Sorry? Th17. Remember I said the major players are Th1 and Th2. Then other are the side players. They will come in as the need be. The major demarcation between, so that's why if you see the original table, I just have two rows, Th1, Th2. I said Th1 is an accelerator, Th2 is a brake. So these are the major one. And then other will come to modulate. So we have a lot of modulators. That's why in this case we have IL-17 released by Th17 cells. Okay? So you can see it says over here, again as a rule, when I ask you a question, the answer is there. So we already, if you pay attention to number B, it just says pro-inflammatory cytokines. Right? And they are by antigen-specific Th1 and Th17, so that answers your question that they are pro-inflammatory. And then again, since they are pro-inflammatory, they would recruit and activate antigen non-specific inflammatory leukocytes. Can you give me an example? Or if I say what are the antigen non-specific inflammatory leukocytes? Just name one. Actually, I did by mistake just now. What are the antigen non-specific inflammatory leukocytes? Name one leukocyte that's antigen non-specific. Neutrophils. Neutrophils. Neutrophils are inflammatory cells, leukocytes. They are there, and then there are many more. But neutrophils are the number one, and why I say non-specific? Because they will always be going to go after bacteria, viruses. They don't need any genetic material. They don't need any specificity. So they will just go and fight. Yeah. Monocytes are also there, but monocytes basically are bigger cells. They're phagocytes. The major, that's why when you go, if you have an infection, right, and they want to do your blood profile, it will come leukocytosis. They will say increased number of neutrophils. They would not say increased number of monocytes. Monocytes are important, but they are not that many. So if you have a pus, that pus basically is dead neutrophils. That's what it is. So neutrophils are number one. Of course, other things can come, okay? So there is a major, so these are 3 steps that will happen. And as I said earlier, there's going to be a storm of cytokines, and you can see interferon gamma is number 1, chemokines, because chemokines will attract leukocytes, and then of course TNF alpha and beta are also there. And we'll take these MCPs and other chemokines as we go along. But right now for this part, just remember is a pro-inflammatory cytokine. Now, if you do remember type 1 and type 2, type 4, again you go for sensitization stage and elicitation stage. So you also saw that sensitization stage in type 1. But there's a little bit difference. So I want you to just pay attention to that. Again, take an example for PPD. So PPD is a purified protein. It was injected in you over here, and then under the skin, and then your antigen presenting cell that are Langerhans type cells, they will take it in, and then they will basically present it to T cells, right? So you can see the T cell would either recognize or don't recognize depending upon if they have memory T cell. And then one of the effector responses of T cell activation is, number 1, they will produce IL-2. Number 2 is that they will expand, proliferate, clone. Number 3 is that they will divide into many different types of cells like Th1, Th4. Number 4 is that they will move out from this area and go to lymph nodes. So there are many things, and then again starts expressing different membrane receptors on the surface. So you can see in this case, this is a blood vessel, and you can see from here they differentiate to Th1 and Th17. And there was another word of caution I will give it to you because I am into the use of social media and so forth. And I don't know whether APP students are right here with me or not. The problem with technology, especially YouTube videos and other stuff, is that so far what I've seen is that the information is outdated. Right? So information is very difficult to keep up with the information which is out there. Okay? And by the time you start looking at them, you may have an old information which may be good enough for the basis, but things do change. And you will see that happening when I teach you today type 4 hypersensitivity from your textbook, unfortunately, which is 6-year-old. And you know what? If some book is published in 2009, what does it mean? Because, say it again? Exactly. So this means that the papers were published at least 5 years before 2009 to get them a print in. So that's a very outdated old information. But again, the question is why are we using it? Because for foundational purposes. So these are the 3 lectures that are foundational purposes, and you will see the intensity of lectures on workshop that we will talk of research. We'll talk of things which are there. And that also reminds me that, as I promised, that I'm going to pick the top 3 students for my research in immunology based upon the exam that you did today. And so far, we're just waiting for one of the students to log in and then validate the data. And I think by the end of the day, if I have nothing else to do but to sit over there and validate the data, So probably I would say 6, 7, something like that. You may see on your I think I'll have to post. I don't know how do they post it? How do they post it? Do they post it on your exam soft or they haven't worked it up? The grades for the quiz. What happened with the quiz, exam quiz? They still posted a Moodle? Huh? Moodle. So or she's on both. Okay, that's the good news. Go both. Okay. So anyway, so let's see what happened. So you can see from here TH1, TH17, and then again TH17. These are tons of cytokines they are produced, and then again one of the effects of those cytokines is that they activate macrophages. And these macrophages you can see, and then neutrophils will come as well. So neutrophils will come because neutrophils are not in tissues. This again concept. Langerhans cells are in tissues. Monocytes are running in blood, and neutrophils are running in the blood. So once there is inflammation, local inflammation, there are gaps in the vessels and they will ooze out, and then you can see the damage is caused by neutrophils. So neutrophils cause tissue injury because they have all those peroxidases. So they carry that bleach, literally. Okay? So that's kind of an oversimplified version of what you see in PPD, right? The immune cells per se don't cause much of a damage directly, but they would release those cytokines, and the list is over here, pro-inflammatory cytokines. They would have done that to fight off an infection, which they will do. And as I said yesterday, once I talk about bacterial infection, I'm going to come back and tell you what kind of immune response this particular bacteria has to fight against. But you pretty much get an idea that they are pro-inflammatory cytokines, and then they will bring all different things over here in the picture and cause damage. Okay? Any question on that? Because that's a major concept. Okay? And what did you notice? Did you notice something in this whole response? What was the special about the response that I just told you? One thing very special. This is what happens when you see a slide, I see it differently and you see it differently. So we have to agree upon something that I want you to learn from. So what is it that you see from here that I see differently? There is one thing which is very prominent if I was to look at different type of hypersensitivity reactions. So I'll give 2 extra credit points to whoever answers that. You have to raise your hand. When you say extra credit, they want me to repeat. When I just say the question, they just do not pay attention. If you compare type 4 hypersensitivity reaction, right, what is it in this type 4 which is very obvious? That's the name of it, cell-mediated. But what's very obvious on this? I'm not saying that you're wrong, but very, very obvious observation over here. Yeah? Dendritic cells? Dendritic cells? Langerhans cells are dendritic cells. There's nothing special about that. Okay. Time out. There's no antibody there. There is no antibody there. Do you see any antibody there? Well, antibody. B cells technically may be there. B cell may be there. But B cells are different than antibody because this specific hypersensitivity reaction does not have antibody at this stage. Okay? So these are some of the major, and that's what actually I said when I presented you the very first slide and said this is the major differences between these two. So anyway, move on. You got so many points today. You don't need extra credit points. That's fine. But I just extended the day, the time for somebody came to me for the extra credit for the YouTube videos. So you still have, I think, 2 more days to earn those 5 points if you are interested. So these are the clinical examples for delayed type hypersensitivity. Contact sensitivity of the skin. Granulomatous hypersensitivity is a granuloma formation. I'll discuss that in detail. Monday, we just talked about tuberculin type hypersensitivity, PPD, and allograft rejection in transplant. Myasthenia gravis, though it comes in a different format, but remember, as a rule, that's why I said I'll just teach you basic before I confuse you. So once in the real picture, what happens is there may be more than one type of hypersensitivity reaction involved. So there may be type 1, type 4, type 2, type 3. So there may be, because this is for our learning that we divide them. And again, this classification was done like 1963. But pretty much good for the basic concept. But as we move along, you will see the rheumatoid arthritis, type 1 diabetes mellitus, multiple sclerosis. So there are quite a few clinical diseases that basically are there, and we'll discuss them, or somebody will discuss with you as we move along. But the point I'm trying to make is, it's good for you to learn all 4 types separately and see where is it coming from. But eventually keep in mind that when it comes to the clinical picture, things may be a little bit of overlapping. That's why you have to use your judgment. Okay. Since for this lecture I'm following the book, so you can see from here one experiment done to find out that the most important cytokine released in this type of allergic reaction is gamma interferon. Now the question to you will be, what are the functions of gamma interferon? And I also told you gamma interferon basically is given IV. So it's to boost the immune response. So what they did was they separated the peritoneal macrophages, like you can see from here. And they saw that once you separate them, they start adhering. And then if you treat them with gamma interferon, they will have better development and adherence. So they will kind of grow and mature, and they will start showing those lysosomal granules which are there. What it implies is that if you give gamma interferon to a person, so the job done by macrophages or monocyte will be really good, because then they will adhere more, they will show more adhesion receptor, the MSC class expression will go up, their antigen uptake will go up, right? And then many other changes will happen that also include some of the expressions of subreceptors on the surface. So gamma interferon is required to activate, proliferate, and upregulate the functions of cells like monocytes and macrophages. Okay? So it's going to assist in the good immune response. Correct? And then they are basically ready to go. Now, if you were to look at the gross appearance, for example, in this case, reaction to poison ivy, you can see poison ivy over here. And if you were to look at their histological appearance, so you will see mononuclear infiltrate in dermis. So remember, we were just talking about that if there is a inflammation there is a non-specific inflammatory cell response. In terms of neutrophils, they will come and take care of the damage. Or there are monocytes. When monocytes come and infiltrate, they basically are coming, so they are invited over there. So this means that these cells, tissues over there are releasing those chemokines and those specific cytokines that will recruit monocytes, because monocytes are special. They are bigger, larger, right? They are going to stay in the tissue for a longer time. And they have more capability to phagocytose bacteria as compared to neutrophils. What other difference do you think is between a neutrophil, and then again it's a blood physiology, it's nothing to do with immunology, in difference of a monocyte and a neutrophil? I just told you neutrophils are first line of defense, they carry bleach, and they are pro-inflammatory cytokine, they are antigen non-specific. If you compare them with monocytes, so what other differences do you know that monocytes have if I was to compare them with neutrophils. They are larger in size, I can tell you that. Monocytes can present an antigen because they are cell with the nucleus, so they can have MSC class 1 or 2. Okay, what else? Nothing? Okay, so you guys are tired, you've been sleeping awake whole night. I feel bad. That's why I said to Elena, I asked her that, do you have any class? So she says 1, 2, 3. Otherwise, I would have stopped here and let you go. But since you're going to be here anyway, so why don't I make best use of that? Okay, we'll stop in 10 minutes. We'll stop early. 2 slides. 2 slides. 2 slides. Because this, actually, I had 9 slides to begin with anyway. So one of the differences is that monocytes are long-lived cells. Neutrophils have half-life of 72 hours. So once they are made by bone marrow, done away within 72 hours. So if neutrophils phagocytose bacteria, so they're going to eat it up or spit it out and let another neutrophil take it. But if monocytes taken in bacteria, either they are going to kill it or keep it forever. So one of the niche is a safe haven that many microbes have found out that if they have a choice to home into neutrophil or make a home into monocyte, they would rather go for monocyte and then stay in your system for the rest of your life. And then come back when the need be. For example, some of the bacteria will sit in the monocytes and hide away, and your immune system doesn't see it, no response, and when your immunity goes down, they will come back and then cause an infection. So that's basically one of the important things that these monocytes have. Okay? Okay, basophil again is the same kind of, when we say leukocytes, we basically mean polymorphonuclear neutrophils, basophil, eosinophils. So these are the 3 important white blood cells. When you say white blood cell, you mean neutrophil, basophil, eosinophil. Okay? So you can see sometimes we have a basophil and some mononuclear infiltrate 24 hours after the skin test. So this basically shows you that specificity of the immune response. As I said earlier, type 4, delayed type, this is a tuberculin reaction. You can see gross appearance showing induration erythema 48 hours after tuberculin test. So you can imagine when you were wondering that you tested over here and you should have a reaction over here, and again you forgot to tell the doctor that you have been vaccinated with BC or you have a TB going on right now, your active disease. So you can see the response, a general erythema response on all your body, because the memory T cells will react to it and they will generate a perfect storm of cytokines, and that cytokines will cause a havoc in your body, and that happens many a time. But also keep in mind that if you want to treat them, so you have to have anti-cytokine therapies. That's what the important thing is. If you look at the histology of that, you will look again in the skin, mononuclear cell infiltrate. So that suggests to you, if it's a mononuclear, monocytic infiltrate, that it is antigen specific. Right? T cells per se would not directly cause damage, but T cell will release those cytokines, and those cytokines will call in pro-inflammatory cells like monocytes, and they will take care of rest of the stuff. Now, simply, this is the last slide, simply your book talks about the treatment, and I'm going to go that in detail on Monday. For any allergies, type 1, type 2, type 3, type 4, you will say remove the antigen. If this is a food, if there is a ointment, if there is a cosmetic, clothes, so and so forth, wherever the source of antigen is, you can identify that and remove the antigen, simple as that. Or you can suppress the immune system. So immune system can be suppressed by corticosteroids. So this means if you give corticosteroids to the patient for treatment, they are prone to diseases. That's why when in asthma, even if they give you steroids, they'll also give antibiotics as well, because steroids are basically anti-inflammatory, which is good, but again, they are short-lived. They have to give it in a short period of time, acute or like a systemic, topical or systemic, but they will lower your immune system. So that's an important thing to understand. Or you can see immunosuppressive therapy. That again, as I said, part of chapter 10. And I did say when I was teaching you chapter 10 that I want only the research students working with me to know what is intracellular pathways. But for allergies, I would want you, the whole class, to know as well. And I'll talk about the intracellular signaling pathways on Monday in detail because of the drugs. And if you remember, if you are interested and you are into drug design and delivery thing, there were cyclosporine and tacrolimus, which is a calcineurin inhibitor. So calcineurin was there in the signaling pathway where it blocked the transcription of nuclear factors like AP1 and NF-kappa B. So these are important drugs that we have. And they're also anti-cancer drugs as well. Okay? So you can see roughly the journal theme of type 4 hypersensitivity reactions. And then again, what I would want you to do is that compare type 1, type 2, type 3, the basic knowledge. And as we move along to see the clinical